Hello and welcome to Healthline 3. I'm Terry Simmons. Today we're talking with Dr. Jay Howell with W.K. Bozier Surgical Associates, and we're talking today about abdominal pain. And we'll be taking your calls throughout the show. And as a reminder, please make sure you're in a quiet room with your TV turned down all the way so you can hear us and we can hear your questions. And the number to call is 318-219-4569, and you'll see that across the bottom of your screen throughout the show. So Dr. Howell, thank you so much for being here.
My pleasure. Happy to be here.
Well, we were talking earlier about your surgical specialty, and so do you want to refresh us a little bit about what you do?
I'm a general surgeon, and that encompasses a wide range of surgeries and different disease pathologies that need to be addressed in a surgical fashion. And I'd probably say the most popular operation we do are gallbladders. We do a lot of what they call cholecystectomies, take out a lot of appendixes, fix a lot of hernias, and then some things as complicated as colon cancer, breast surgery, breast cancers, and more superficial tumors of the skin and subcutaneous tissue.
So it really is that general.
It covers a wide range, which is what I like about it. Certainly we're very lucky in this area. We have some gifted surgeons who are specialists who only concentrate on certain areas of the body, but I kind of feel like I get bored easily, and I need to be able to do a wide variety of things, which I think makes it very interesting and what I enjoy.
That's really remarkable. You hear different specialties in one area, but to know, like you said, if you do like that variety, to be able to work on every part of the body must be really gratifying too, to be able to know there's so many things that you can fix and help people with.
Yes, it is gratifying, but it's also it's also nice to know that if I do have something in one of those specialized areas, if I've always felt like in my practice, if someone can do something better than me, that's who the patient should be seeing. So we're lucky earlier, for example, we're talking about Dr. Altman, who does thyroid and parathyroid surgery, much better at that than I am or would ever be, and certainly I would send those patients to him. So it's nice that we have that community here and those specialists available for when we run into those more complicated areas.
That's an interesting point. If you're a general surgeon and you could, but you see something that that a specialist who could really be, really get in there and that might be a better fit, that you can. I never thought about that you could do that and just send them to someone else. Not that you couldn't do it, but like, oh, I know someone who's really, this is who you need to be with.
Yes,
yeah.
and some of these operations very difficult and complicated, and it's better for the patient to be with someone who does this all day, every day, and and that's what we're supposed to be doing. It's what I feel like I do. Is you want to get the patient the best treatment you can get them.
Yeah, that's it. And so you see mostly gallbladder appendicitis. Is that what you do mostly in hernias during the day?
Yes, and general surgery, again, the variety, you just never know what you're going to get. I have patients who are sent to my clinic for specific disease processes. They'll have some abdominal pain. Their primary physician will discover they have gallstones. They'll send them to me to get their gallbladder out. Well, while that's going on, I may have a patient come in the ER with possibly a bowel obstruction or appendicitis, and I'll have to address those issues as well. So you just never know what you're going to get every day.
Like you were saying earlier, this morning, tell us what you did this morning before you got here.
This morning I had an elderly gentleman, had a cyst on his elbow, very straightforward. Just took a few minutes to get that squared away, and then followed that with a 20-year-old that had appendicitis, needed his appendix out, and then had time to go home and get cleaned up a little and come up here, or as much as I can clean up.
I thought I had a busy day through doing some things, but like it's amazing and that's who you want. You want that person that can do, working on people's bodies. Doing surgery and helping people, and that's what you do in your day, and then you can come here and talk with us, which is we really appreciate you taking time out of your day to do that.
Sure, well, I'm happy to do it, and I was lucky that to be taught how to do all these surgeries. I didn't just innately know how to do any of this stuff. It was a long and arduous training process, but I had some great mentors and learned a lot, and still learning all the time. There's just new technologies coming out all the time, and it behooves you as a physician to stay abreast of these technologies. Some will fall by the wayside, some will stick around, but you should know about them.
Right, and I love that you were talking earlier too about the opportunity you had. You were in your hometown practicing in Natchitoches, and it's a smaller town, and people were going outside to Shreveport, Bossier, and other areas for surgery, and so you were given this lovely opportunity, or sought it out and got to come here, and that's when you moved here. It's like you said, okay, well, I'll just meet you there. That's where you're going for surgery? Yeah.
It was, everybody always had this feeling that I wanted to practice in my hometown where I grew up. So I love my hometown, family there, and the hospital had a need, but it was just, it just wasn't busy enough, unfortunately. You know, I did a lot of self-reflection. Is this my fault? Am I doing a bad job? Or talked to some of my mentors who made me feel much better. And Dr. Banda, who I had trained with a couple years older than I was, had a wonderful opportunity here in Bossier, and I was humbled and blessed that he called me and asked me to join that practice. And it just completely changed my life. I was able to provide better for my family, which has always been important for me. I love my job and I love helping people, but I feel like family's always been my priority. And I was able to provide better for them, being a very active, busy practice. I love to be busy, and have a great partner in Dr. Banda, who's just an outstanding surgeon himself.
Well, how lovely that it all worked out for you.
It really did. Just better lucky than good.
Yeah. And you're not too far from your hometown.
No, not at all. Still get to visit.
Right.
Still get to see my mom all the time, who's probably in better shape than I am. She's doing great.
She's good.
She's great.
Okay, well, we actually have a caller for you.
Sure.
Hi, Sam. Thanks for calling. What is your question?
Yes. Thanks for your program. Do y'all, or your group, or do you know of a surgeon that would perform the surgery for that is a zinker that's in your throat? I think I don't have all the technical name, but zinker is one of the words on it.
Yes, I know exactly what you're talking about, and I do know a surgeon who provides that. And I think the best way we can actually help you with that and help get you an appointment and schedule you, if you'll just call my office at 746-4460. I will make sure my staff has the information for that surgeon, how to get in touch with him, and we'll help schedule that appointment for you and hopefully get you taken care of.
I wasn't ready to write that down. What is that number?
746-4460. That's my office at Willis Knighton, Bossier, and we'll be happy to help you.
Thank you, sir.
You're welcome.
Oh, good luck to you. So what is that he was talking about? Do you want to talk about that procedure or that condition?
I could talk about the condition a little bit. The procedure is outside of my realm. That's where we need one of these specialists for.
Exactly.
But a Zinker's diverticulum is a weakening of the musculature around the esophagus, the tube when you swallow food. The esophagus carries food from your mouth to your stomach. And there's a couple of areas where the musculature can be weakened, and you can get a bulging of the esophagus, sort of if you squeeze a water balloon, it will bulge around your fingers. It's a bulge like that. And it can trap food particles and can be rather bothersome, and there are some ways to get in there and get rid of that little bulge. That's about all I know about as far as the technical aspect of it.
It's such a great example of what you were talking about, though.
Yes.
You know, being a general surgeon and knowing who to call if not. And we talk a lot about how even if you have your doctor, you want to call a doctor, you have something, you don't really know who to call. You don't know what kind of a specialist would handle this. To just start somewhere. Call your doctor, call a general doctor, call your primary care. Start somewhere and ask someone, and chances are, at least that doctor doesn't handle that, they know where to send you, especially with Willis Knighton.
Absolutely. Well, Willis Knighton, first off, we're super lucky to have so many great specialists and subspecialists in the system. It just covers the gamut of all specialties. And I tell my patients this all the time. I say, you know, I may not know the exact answer, but I bet I know who I can get you to who will know the answer. And I do see that sometimes. Sometimes I do have patients who come in and I'm unsure of the exact way to go with that patient or the exact treatment modality, but I do know who will know, and I'm able to get them to that person.
Right. And today we're talking about abdominal pain specifically, yes. But there's also some things before we get into that. Let's talk a little bit more about where you are and the changes that have been happening there and the opportunities.
Yes, well, earlier this year, and it's been in the works for a couple of years, some of my colleagues, specifically Dr. Ghazi Zabari, who's not only locally renowned in the South, but just a world-renowned, outstanding surgeon, one of my mentors. He's a hepatobiliary surgeon. He and some of his colleagues and some of the Willis Knighton administration got together and felt that they had enough to offer surgery training-wise to start their own surgery program. So they have started a surgery program. We are now training young surgeons, residents. Those are people who have just graduated from medical school, decided they want to be surgeons, and they undergo the residency program to learn how to operate. So for the first time since I've been out of my own residency, Dr. Band and myself have the opportunity to train young surgeons, teach them how to operate, and it's been a very different experience for me. I remember, it's hard for me to remember when I first started operating, things weren't intuitive. Now I walk in the operating room, it's like you're reading a teleprompter. I don't have to really think about it too much. I know what I'm doing. I'm focused, but most of it's reflexive, just from having done it thousands upon thousands of times. And then I have these young surgeons who don't have any of that reflexivity and are just learning and trying to, learn how to properly hold instruments and things like that. And I think even in this short time, I think it's made me better because I have to explain to them how to do it. And if I don't know how to explain it, I probably don't know how to do the operation. So it's nice that I can relive that and explain it and see them grow and become better surgeons, even in just a couple of months' time, which has been really, it's kind of revitalized my practice, I think.
It's really interesting, isn't it? Now, sometimes we're the teacher, sometimes we're the student, and then when it comes back around, you're right. You do things so intuitively, and you've done it so much, and you really can follow your gut. But when you have to tell someone how you did something, it's different, or tell them how to do it. But then you relearn it. You just stay open and you relearn it as you're teaching. It must be a really great feeling. Yeah,
that's a great way to put it, and it is a good feeling. And some things, I need to be probably better at my teaching, because sometimes I say, look, I'm not sure how to tell you how to do this, but you just have to put your hand here and kind of wiggle a little bit, and that's how it's going to work, And I think I will get better as time continues, but I know what I am good at, and I feel like I'm good at being safe, because surgery is a lot like flying a plane. If you're not safe, you just have nothing. And I just stress that all the time. I'm like, we're gonna do the operation we came to do, and we're going to do it safely, and then everything else we'll just deal with. But those are our two main points, and if we can do operations and be safe, then we're going to be good at what we do.
Right. I think it's so important, because you and I have talked about before how many you've done in your span of years, and it is intuitive, but also you're aware every time. It's a brand new body, it's a brand new surgery. It's new every time, and you have to stay in your moment and be safe and just realize that. So it's really interesting that you really do just stress the safety. You
have to, and you're right. I'll do a gallbladder at 7 o'clock on somebody who weighs 130 pounds. I'll do one at 8 o'clock on somebody who weighs 450 pounds. And even though it's the same operation, things are markedly different. There's markedly different approaches. There's all sorts of little tricks that you learn over the years that you can do to make things easier on yourself and thereby easier on the patient.
All right. We have another call for you.
Sure.
Chip, thanks for calling. What is your question?
Yes, I was wondering what I have a steel plate that was in my leg and put in 1979, and now I'm having problems, and I'm having a problem finding somebody that will take it out or help me out.
Okay. Well, I'm saddened to hear that that thing is giving you trouble. Sounds like it's been in there for quite a while. That's actually an orthopedic issue. I'm not an orthopedic surgeon. I don't deal with steel plates or any bony abnormalities, but certainly I would encourage you, as I did the last individual. I do know some gentlemen who are on our campus out there at Bossier who are outstanding orthopedic surgeons. Be happy to refer you to them, and we'll help set up the appointment as well. Just 746-4460. And we'll be happy to help you.
Okay, appreciate it, sir.
All right, you're welcome.
And good luck. Thank you so much for calling. And so let's go into the abdominal pain now, which is the reason you're here to tell us mostly about that, which is so interesting because it's a broad subject, but then you can tell us, like, when do we need to really go see the doctor? There's different kinds of abdominal pain and stomach pain that we can identify. Oh, we have Iris on the line. Sure. Hi, Iris. What is your question?
Hi there. Well, it's been about 10 years. I had some polyps that were too large to be looped out, and they had to do surgery. And I lost part of my colon, my large intestine, and my small intestine, and the part of my stomach that grinds food. They were all taken out. But I keep having hernias. And my question is this normal? Do you keep having hernias or what? I've had 2 or 3 of them taken out, but I just have 2 now that have come back, and they seem to say, let's watch it. But I was wondering, am I doing something to cause these hernias? Just normal thing?
No, ma'am. Hernias, there are several different reasons why we get hernias, and your story is not an uncommon story for hernias. The more surgeries you have on your abdomen, the more prone you are to develop hernias. The more attempts you have to fix the hernias, the more prone you are to develop hernias. Any disease process that you could have that could make it difficult to heal, such as if you're on steroids, if you have diabetes, being overweight will also put you at risk for hernias. Smoking is a big risk factor for recurrent hernias. But certainly I would love for you. You can come by my office. I will sit down, examine you, take a look at these hernias. This is what I do all the time. I get referred a lot of complex hernias from around the surrounding areas, and I'm happy to help get this problem resolved for you, and we'll give you the best advice that I feel we can give you.
Okay, well, I would appreciate that, and I thank you for talking with me.
Yes, ma'am, my pleasure.
And thank you so much for calling. And so that is common. Why would it be? Is it because it lessens the muscular tissue? Why is so many, like if you have more than one abdominal, the more abdominal surgeries you have, the more hernias you can have? Why is that?
So the one of the main components that holds, I'll just say, like I talk to my patients, and I just like to talk very non-scientifically, so I think everybody understands better. One of the components that holds all your guts in place is what we call fascia. Which is basically gristle, like you have gristle on your steak. This is the gristle that holds things together. It does a great job. It's very strong, but unfortunately it has a poor blood supply. So the more you enter the abdomen and mess with that gristle, the less blood flow you have. You need good blood flow for healing. So the fascia doesn't heal as well as it would if you had not violated it ever. So when that has trouble healing, it's not uncommon for it to become weakened and predispose you to have further hernias. And there are certainly many different approaches to hernias. There are a lot of different types of hernias. There are some hernias, I've fixed some that are maybe as big as a marble. About 3 weeks ago, I fixed one that was about this big, hanging down to the patient's knee. So there's a whole bunch of different spectrums of hernias, and this lady that just called, I could examine her, see what types of hernias she has, figure out the best repair for her. And sometimes I will tell you, I'm not sure what repair I'll do until I get in there and actually see what's going on. Sometimes there are smaller hernias that we just can't feel with exam that we don't see till we get in there and operate. So I would tell her, just like I tell all my patients, I can't tell you exactly how I'm going to repair this, but I can tell you I'm going to do what's right, and we'll get in there and we'll fix it. And I certainly run into that all the time.
It seems like with your surgery, more than not, that general surgery, getting in there, you really don't know what you're ready for anything. Once you get in there and really see what's going on, that's when you make the decisions. And that's where your intuition really comes in well.
Yeah, well,
right?
it's good that, and experience is super helpful. And I was so lucky to have such good mentors and professors that train me to face a whole lot of different situations. You just never know what you're going to run into. You're right. Yeah, sometimes you get in there and you think you're going to go south and you end up going north. You find something unexpected, but luckily I feel like I've been trained well enough and had enough experience that pretty much we're going to handle whatever we run into.
And there's always training for the more advancements. I mean, you're always learning and training.
I am.
Not with just the experience you're building, but there's always.
Yes, there's always, robotic surgery is real big now. I did train in robotics, did it for a few years. It just wasn't a good fit for my practice, so I've let that go by the wayside. But we do have some great robotic surgeons here in town, and again, every now and then I'll find something I think is better addressed with robotics, and I will send that patient to those surgeons who do a great job, and we're lucky to have them.
And that's a really good thing to bring up too, because we do talk about robotic surgery a lot. And so, is it a preference? Like, if you did it, you trained in it, you can do it, but you like this kind of surgery the best? Yes,
there were a few different reasons why I didn't stay with the robotic surgery. I think one of the main reasons is what we call turnover. When you finish operating, they have to get the room cleaned, re-sterilized, everything reprocessed, ready to go for the next patient. And it takes probably twice as long to do that robotically. And if I only had 2 or 3 operations to do a day, no problem. But when you have sometimes as many as 10 or 12, it's just inefficient. And I hate for patients to be waiting around all day. It just wasn't a good fit for just the 2-man practice that we have. That's how I felt.
And Dr. Howell, I think that's just the thread of this here. You like to stay busy.
I do.
You want to help as many people in the day as you can and do that surgery.
I like to kind of go.
You know, that's really remarkable and quite a gift. And so, what are the most common underlying causes of abdominal pain that you see?
The most common I see is going to be gallbladder disease. These patients commonly have classic symptoms after they eat. They get upper abdominal pain, often with nausea, typically subsides within 30 minutes to an hour. We have a great primary care network at Bossier. They're so good at spotting this problem. By the time the patient gets to me, they've probably had every test they need to have. It's all done. I just need to talk to the patient about the operation and how we're going to help them. And I probably do, just myself and Dr. Banda each do between 300 and 350 gallbladders a year.
Okay.
So it's pretty common.
Goodness. We have Carla on the line for you. Hi, Carla. What is your question?
Yes, my husband is, he's had a heart transplant for 20 years, and he has an abdominal hernia, and it's about the size of a basketball. And they never went in to fix it because, you know, he's a transplant and he has to take the amine sufficient medication, and they were afraid of an infection. And with that Johnson & Johnson mask they were using. So I was wondering, because this doctor's talking about he does a lot of hernias, and we just wanted to see what he thought.
Yes, ma'am. I understand what you're saying, and I think probably it's two-sided. Being on the drugs to combat his immune system puts you at a higher risk for infection. Also makes it more difficult to heal up. So it could certainly put you at a higher risk for surgery. But this would be something that I get referred to me all the time. I would be happy to take a look at him and see if I thought we could safely help him. Again, safety first. And I would be happy to evaluate him. If you want to come by for an appointment, it would be my pleasure.
Yes, sir. Can you tell me what your name is? I can't see it on the television.
Sure. James Howell, Howell. My office number is 746-4460.
Okay, I'm sorry. 746?
4460.
4460. In the beginning of it is 746.
Yes, ma'am.
Okay, well, thank you, and I'll call your office.
Be happy to see you.
Okay. Thank you.
Yes, ma'am.
And so tell us a little bit about gallbladder disease, like the clinical, the diagnostic work, the treatment, just you want to run us. Oh, we have Sandra. Hi, Sandra. What is your question for Dr. Howell?
Yes, I have a daughter that has had actually multiple surgeries, but two in her abdomen, and I have to say she complains, in other words, of not being able to have a bowel movement, like for 6 to 7 days sometimes. She stays bloated all the time, and I don't know that she's ever been, checked for gallbladder issues, but I'm just concerned about her because she's always uncomfortable and naturally still working, and so it makes her at a desk all day. And so that she didn't get that much exercise. Actually, I know maybe it's a problem. I don't know, but could you tell me? See that one of the surgeries was a hernia, and the other one was where they had to go through the front to operate on her back because of issues that she had. So anyway, I was wondering, could you tell me or advise me who she should go to?
Yes, ma'am. Sure. The problem you describe, there's a whole bunch of different reasons we could have these issues. Not all of them surgical. Usually, the best place to start, where we have some very good gastrointestinal physicians. There's a large gastrointestinal associates (GIS) group that I would start with. That's usually the best place to start. They can make sure you don't have any type that she does not have any type of anatomical abnormality or something that would need surgical correction. A lot of times just some dietary changes and lifestyle changes can help with these issues, but that would be the best place to start. They're outstanding at addressing these type of issues.
Okay, could you tell me who they are?
Gastrointestinal specialist.
Mm-hmm. Oh, okay. And where they're located,
They are located in Shreveport on Greenwood Road.
Oh, okay. Thank you so much. Appreciate
Yes, ma'am.
that.
My pleasure.
You have a blessed day. Bye-bye.
All right.
And some of the symptoms she listed. Speaking of symptoms, like what are the symptoms? What's the difference between gallbladder disease and appendicitis? Is it a different kind of abdominal pain? And does it move? Is it sharp? When do we pay attention and really go to the doctor?
Well, I'm a big fan of if you have recurrent issues. Everybody's going to have a little stomach ache from time to time, but if you have something that is either last a long time, if you have longevity or recurrence, those are the two things that I caution people about and feel like they should get checked out. Appendicitis is a disease of acuity. You're going to have appendicitis. It's going to begin to hurt, usually around the belly button, and then down on the lower right side. It kind of migrates over there over about a 24-hour period. And if you don't get that addressed, it gets worse and worse, and it'll eventually rupture. So that's a disease of acuity. If you have appendicitis, you're usually not feeling too well. You're not going to need anybody to tell you to go to the ER. You're going to want to go to the ER. Whereas gallbladder is more of it's more of a recurrent issue. It's not so acute usually. You can certainly get a bad gallbladder attack that would cause you to go to the emergency room. But often these patients have recurrent pain after eating, nausea, usually subsides after a little while, where appendicitis is usually not going to subside. You're going to have that until something bad happens. Hopefully we can head that off before it happens.
Okay. And if we hear this all the time, if your appendix bursts, what are the dangers of that happening?
Well, there's a lot of issues that can come with a perforated appendix. One of the main problems is the spillage of the appendiceal content, which is going to be pus and probably some stool. You don't want that spilling into your abdomen. It can certainly make you very septic and sick. Even in 2022, we still have people who die from perforated appendicitis. You would think that'd be something you just hear about in the medieval times, but it can be very deadly. And that's why sometimes we actually will take out an appendix. If we are very suspicious you have appendicitis, we'll go in there, and even if the appendix looks normal, we go ahead and take it out. Because heaven forbid, if you ever miss an appendicitis and somebody perforates, that patient could be in a life-threatening condition.
So that's something you can just live forever without. You just
Absolutely,
yeah.
yes,
So
no.
what is the purpose of appendix then?
Well, they think that back when we were cavemen and scavengers, eating carrion and whatever we could find to eat, that it's got a lot of lymphatic tissue in it, and it helped us keep from getting sick from eating those things. It helped filter bacteria from whatever we could find to eat. But that purpose has long since been served. And so it doesn't really do anything but cause trouble now.
Which makes sense. If it was filtering toxins and bacteria, that's what it holds, which is why that's dangerous.
It is. It is dangerous because the appendix, once it gets kind of clogged up, it will swell. It'll fill with fluid. The fluid will get super infected, and it's just an ugly condition.
Yeah.
But luckily, treatable with laparoscopy, 3 small incisions. Maybe takes 20 minutes if it's a difficult one, and usually home either later that day or the next day.
And the recovery is just from the actual surgery, right? So it's just
it's not too bad at all,
yeah.
the recovery. Just probably a few days of feeling a little sore, and then you can kind of start getting back to your routine.
And so in gallbladder, different. It can sneak up on you. It can happen. It comes and goes. Is there anything where it flares up? Is it eating that makes it flares up, or food, or?
Usually the classic story is fatty or greasy foods.
Okay.
The gallbladder stores bile. When you eat something fatty, it squeezes a little bile into the intestine to help you digest the fats. So when you eat something fatty and the gallbladder tries to squeeze, there's stones in the way, it swells up, it gets angry, makes you angry, and then you feel poorly until that subsides.
And gallstones, like what are they made of? How do they come about? Why is that something that forms in the
Well,
gallbladder?
there's a few different types of gallstones. What happens is the bile is made up of 3 different components, and if one of those components gets a little out of whack, you'll begin to precipitate stones, and the stones will get bigger and eventually become large enough to cause trouble.
Okay. And so so you can someone, if it's mild and they have gallbladder trouble, they can go on for a very long time, or?
Some people can't. Some people just live with a bad gallbladder. They'll just got it, especially some of the older generation. They'll be like, I just got used to this belly pain. I've just had it for 30 years, and then we have some patients who are extremely sensitive to it. They get one attack, they're ready to come in for surgery.
Okay. So speaking of abdominal pain and all of them we talked about, what is something that you'd like to leave us with today?
Well, I think a couple of things. Number one, if you're having recurrent abdominal issues, you need to see your doctor. There's just such a wide range of things that this could be, and we're lucky in this community. We have a great healthcare community here, and if most of the physicians are like I am, if they can't find the answer, they'll find somebody who can. And I think that mostly prevention is the best cure. You want to get that gallbladder out before you have a terrible attack or have a gangrenous gallbladder or any of these awful other issues. You want to get these things taken care of before they get out of hand. and I think that's prevention is the best treatment.
Prevention. Don't be afraid to ask. Don't be afraid to go in and see, and don't be embarrassed. You're afraid it might not be anything. If you have pain that's giving you discomfort, then go see about it.
I would, yes, absolutely.
All right. Thank you so much, Dr. Howell. It's been a pleasure.
Yes, ma'am.
Thank you for joining us. We'll see you next time on Healthline 3.